I'll just kick off just now in the interest of time because we have only got the 25 minutes. So first thing, just if everybody could make sure that they've got the Slido app downloaded on their phone. If you've not, you can get the QR code on the front of your brochure, and also just to make sure that you've got the Hub 1 and 2 selected so that you can ask any questions through the app. Without further ado, I just want to introduce Shamira Bright, Chief Commercial Officer of Onebright, Graham, to talk us through our presentation. Thank you.
Thank you. Morning, everybody. Really nice to be here. So, yeah, I'm Shamira Graham. I'm the Chief Commercial Officer for Onebright. Onebright is a large mental health provider. So we have the privilege of working with 60,000 patients every year. So we sit and power most of the private medical insurers that are here today. We also have a number of occupational health pathways delivered directly to trauma and occupational health and blue light forces as well. And we have lots of direct to corporate contracts. So the reason for saying all that is actually probably in terms of people in this room, we have got some patient data here which probably matches your populations. So you're here today to think about mental health risks within your organisation. So I'm hoping today that some of the themes that we're going to cover will resonate. I also think that I should get the prize for the longest title for a talk today. So lots of words there, but it's really important. So we're thinking about intersectionality. So we're thinking about mental health and the contributing risk factors. And that's important when we start thinking about early intervention and prevention. I'm also a treating clinician, so I've got the amazing privilege of designing propositions and pathways and also sitting and working on them clinically. Okay, so this, I would like you to really think about this. When I do lots of these speaking, I always start with this slide and this principle because this is your take home from today. Mental health and well-being is a continuum. At different points in our life, we will all, everybody in this room will move up and down the continuum. It's dynamic, it's contextual, and we respond to what is happening around us today. So we're thinking about health events, we're thinking about life events as well. So this is just a guide for you to think about how potentially, where are you today? Are we down this blue, greeny end here? Are we moving into unsettled and ill health? So as a treating clinician and as a clinical organisation, most of our data comes from D&E. So this is mostly where people have had a referral via their occupational health, their HR, or when they've made a claim via their private medical insurance. So most of our data is sitting here. Then we thought, hang on, we've got all this data. What if we could look and examine this data and think about what are the risk factors, and then we could address them earlier so that we potentially could move our corporate populations down the continuum so that we could optimise health and well-being. So that is the principle that we're going to discuss today. Okay, so let's take a look at some of the health risks today. So first to say, in terms of gender, we have to think about, we work with health code in terms of invoicing, so this is a caveat. So you will see today that we're talking about male, female. That's largely because that's the demographics that are required for us to collect today. Okay. So if we think about our life events here, so our health events, we will all, male and female, at different points in our life, we will all experience these health events here. And crucially, the people that you're thinking about designing the benefits for, thinking about your well-being provision, will also experience these events here. And it's about navigating them. So just hold those in mind. So then we combine with the lifespan. So employees, us all, will go through a lifespan in our working career. So we will enter the job market, potentially our first professional first professional job, and we will be trying to think about cost of living crisis, and we will be concerned about our financial well-being. So this, again, is presented in a linear manner. I'm not assuming that anybody is working through this in such a linear manner. There's also, so then you enter the job market, there's pressures that we see, particularly in Gen Z, striving to perform, outperform their peers, and we know that that can impact and compromise mental health too. You may be thinking about creating partnerships, romantic partnerships, intimate partnerships, and what does that look like? Where are you living? There may then be pressure for parenthood in some way, be it IVF, be it more sort of traditional routes of pregnancy. And then we have a family, they may grow up, and this is what we're seeing. So the impact of children's mental health on an employee's mental health. This is a really big trend at the moment in our industry. Career challenges. So we've got some data which really speak to potential redundancy factors as well. Career challenges in terms of, organisations right-sizing. We're seeing that at the moment. Lots of people being the impact of AI hitting in terms of jobs. So lots of career challenges, and then potentially we get into caring responsibilities. So we know in terms of women that 74% of women will take the primary caring role for aged parents compared to low 40s for men. So we're thinking about there are all these factors at play which we know are contributing risk factors to mental health presentations. Financial well-being runs through this. I know there's lots and lots of panels here today talking about financial well-being, but it really is important to acknowledge the impact of financial well-being on mental health. Okay, so Slido here we go. So one of those markers, I've just picked it out, is parenthood. So let's just think about what do we think is the occurrence of postpartum depression in women and in men? Have we got our Slido? Is that up? Can someone give me the nod? Yep. Okay. So it's men first and then women. Hopefully we will. Do we get the results of both of them? Lots of movement. Okay. Have we all? So, has men landed? Okay, so we have got to 1 in 8 for men. And can we just go to the women? 1 in 4. Can I congratulate you on being an educated audience in terms of postpartum rate? So the reason that I picked this particular question, obviously I could have asked hundreds, is around that actually in corporate mental health, prevalence rates of postpartum depression in men is just underreported. It is it's just not part of the noise that we hear about. So why is that important? So let's think, if we're thinking about early intervention and prevention, we've got an employee, they go off on either shared parental leave, paternity leave, they come back to the workplace where we're asking the same of them, and we're hoping that they are productive before they went off. Actually, they're holding this health risk. We've got lots of data that supports this. So as organisations, we hold that in mind and we're thinking, actually, when we're focusing on early intervention and prevention, what could we do for people returning to the workplace, for men returning to the workplace in the first year post the birth of their child? Because we know this is an increased risk. So it's around the 1 year mark. Once you move past that in terms of age of children, this risk reduces. So it's about, do you put in extra wellbeing checks? Do you make sure that that individual is signposted really well? Do you make sure that they're potentially you pathway them into your parent network if you have one? So it's knowing, using the data in your organisation. But well done on guessing the prevalence rate. So you definitely, you were the right audience. Sorry, that says 1 in 10, but it's actually, so the answer is 1 in 4 for women and 1 in 7 for men. So you were almost bang on, so that's fantastic. But it's highlighting the principle of using the data, taking action, and moving your people down that continuum. Okay, so data. We have got, because of the 60,000 patients that we see every year, we have got more data than you could ever imagine, and it's always a challenge for me to try and pull out some themes. So what we're looking at here, so this is a private medical insurance data set. So we are looking at here, so this is the percentage of claims. This is not absolute numbers. And you can see, so percentage of change, looking at males first, and we can see number of claims versus age range. So we can see 6 are not working, but that shows that we also run children's services as well. So we can see here that actually the peak of a presentation, so ill mental health, people accessing their private medical insurance in males is really concentrated 26 to 45, okay? So when you're thinking again about your well-being strategies, about your benefit design, this is what you need to be targeting in your male population, okay? So let's turn to females. Again, percentage of referrals made on private medical insurance pathways. And actually we see a bit of different pattern here. So thinking about focused, targeted interventions, thinking about moving your people upstream into preventative action, there's 2 key call-outs. 26 and 35, and we've got this nice curve there in terms of 46 to 55. So if we refer back to the first roadmap, what do we think could be happening at that potentially that point in women? Yeah, absolutely. So in our data, we see actually it's a compounding effect. So we tend to see perimenopause symptoms hit here, which actually can manifest as anxiety disorders and depressive disorders, and actually are quite often misdiagnosed. Accordingly, we also see potentially caring responsibilities for older ones creeping in, and we know that women tend to hold that burden. And then we also may be dealing with potentially challenges of children's mental health, flying the nest, going to university. So I have just have had a daughter doing A-levels. I've had my son doing GCSEs, and I've also had lots of significant family illness, which has required me to drive up and down to Dorset at multiple times over the last 6 weeks. And I can understand how. Obviously, I'm a clinician, so I can self-regulate, and I've got fantastic support. But actually, this is really quite a difficult time. So when we're thinking about contributing risk factors to mental health presentations, this is some really good guidance for you to consider when you're developing your mental health strategies. Again, more data. So slightly different data sets. This is a direct to corporate population. Sorry, so this is where we're working directly with corporates, so it allows us to get a little bit more data from them. So the question that we ask is, can you state your primary reason for seeking help in terms of clinical services via Onebright? So we can see here we've got work-related, non-work, and both. Okay? So non-work related is actually 26 to 35 and 56 and our 36 to 45. So quite an interesting factor there. And then work-related here, 18 to 25. So there's something happening here for our Gen Zers in terms of they're accessing support directly related to work, and again in 46 and 55. So our data tells us that's primarily because they're trying to establish, they've gone from high achieving academic performance, and actually they're now in the workplace, they're competing with their peers, actually competing for jobs. And then 46 and 55, we see this interesting spike. So people at a much more senior level in their concerns, actually, are there a fear of redundancy? Do they think that the younger generation are coming up in terms of their roles? And then switching to women, it's different. So this is the same organisation. And what do we see here? So, call out. 46 to 55, non-work related. Mostly all female referrals in this segment are coming forward for clinical support for factors not relating to their work. So as you, as you know, in charge of reward and benefit strategies, HR directors, etc., you're probably focusing on the blue bars at the bottom and trying to manage and minimise those occupational risks. But actually, there's something interesting happening. So when we go back to our beginning of our roadmap, we're thinking actually what is happening in that. So it's the same compounding events that we've spoken about previously. So this is actual real life clinical data and how to apply that in your organisation. More data. Again, just a quick summary here. So left-hand bar, we are looking at, this is the population mix. So this is actual population mix in the corporate. And again, we're looking at the referrals. So females are significantly over-indexing in coming forward for mental health support. We also know that they're more clinically severe when they do so. So we mustn't forget, we mustn't forget men in this. So actually, challenge to you all is, have you designed benefits, have you designed your mental health provision that actually is accessible to men? So we do know that females have got a higher rate of mental health, but we need to be thinking about, actually, are we ensuring that males are accessing pathways when they need to? We know that traditionally men seek help much later than women. And so it's thinking about how can you do that. So we have just, we're working with a utility organisation which has got a very heavy male gendered population. And so we've really had to scratch our heads and think, actually, how do we encourage them to come forward to work? So it's an OH-HR pathway. So in terms of traditional referrals in, their manager would discuss an issue with them, they would go to HR, and they would come to us. But actually, we were noticing that we weren't getting enough people coming forward to match the size of the population. So we pivoted. So we said, how about we pilot a self-referral? So there's a QR code, you scan it, you come straight into us, so you don't go via HR, and let's just see what happened. What do we think happened? Numbers went up. And that is a beautiful example of, think about the entry to your pathways. So you might have the best provision in the world, but if you're not targeting your interventions to your population and how they access that, people won't use your services, and you will be left with ill mental health in your organisation, obviously high levels of mental distress and the correlated impact in terms of performance and productivity. Okay. Debt, this is just a real whiz through. So the question is, can you, at assessment, yes or no, does debt as a factor relate to your mental health? Okay, so we've got no and we've got the green yeses. Because we've got, this is 2023, so when we first started, 12%, something hit, called cost of living crisis. And actually, I'm pleased to say Q1 2025, we're back to 23%. So again, a really good illustration of how financial well-being is impacting directly on people coming through to make clinical claims. Okie dokie, quick time check. So another model. We love data. We love models at Onebright. So what we've got here, we've got vulnerability on the x-axis. So vulnerability is a bit more fixed than our stress presentation. And this is really informed by genetic loading, temperament, and socioeconomic factors. So we've got vulnerability as a concept along the bottom. And then we've got stress, which we've already discussed is dynamic and contextual. Most of your workforce will be in the green box there. But you can see that actually probably a quarter to a third have tipped into illness. So this is where typically people would come forward to Onebright's clinical services here. So in that segment there. Okay. We can also see that actually if you've got high vulnerability, data to get you into illness is quite low, i.e. the likelihood of you tipping into ill mental health is quite high. Just through the factor that we're all standing and sitting in this room, and you might have private medical insurance, most people are sitting here because we know that that's driven largely by socioeconomic factors. So therefore, the gap that we've got to get from here to tip into illness is quite high. So, i.e., we are really resilient individuals and we can absorb life events as they happen, okay? So an example of some of the risk factors we spoke about earlier are down the right-hand side. What we see in our clinical presentations is a tipping point. So many people have gone through potentially all of their working careers. They've navigated it well. They've managed their mental health. They've managed to keep themselves in that beginning of the continuum. And they will probably have dipped into compromised health, but they know how to regulate themselves and they will bring themselves back. But what happens is we get a compounding impact. So many people, when we assess, will come in, they might have had a recent bereavement, it might be the factors that we spoke about, it might be perimenopause, aged parents, children going away, risk of redundancy, role transition at work, so multiple factors which actually have taken a very resilient and robust workforce into and tipped them into ill mental health. So this is why it is so essential that in your mind you're holding in all the health factors and all the life events and thinking about what do I know about my people, how can I take action to support them. These things are going to happen. Okay, so the risk factors in life are going to happen. They are inevitable. So it's about what can we do to support our people when those events happen. And that is what early intervention and prevention is. Okay, so we are now at what you can do with all this data here. So the first thing is you have to know your people. So if we think about the generational data we've looked at, if we look at the gender split that we've looked at, age factors, you need to know your people. You need to stratify them. Who's in my workforce? Where are they at in their life stage? And obviously think about DE&I. As well. So that is the first thing. Listen to what they're saying. So if we think about the occupational health example I gave earlier, we just can't keep doing the same things. It's about doing things differently, and your people potentially will sometimes tell you what that is. Use the data that you've got. So I'm here today because I can decode the data, because we sit behind all these organisations. I've got the data, I'm decoding it for you, but really push your providers to get your data, and you will be able to get some fantastic insights from that. Think about what you've got for provision. So, for example, lots of people, Peppy as an example, we've all got our lanyards with Peppy. They have come into mental health market because actually there was a gap. So there was a gap in provision, so their population wasn't being supported. So think about, who are my people? What do I have? What are my reward benefits? What are my health benefits? What well-being apps have I got? Do I need them? Do my population want them? Do they match the health risks in my organisation and the life events that my people are going through? So really think about your provision. And then the key question, what are you doing to upstream? So we're back to the continuum. Lots of people making claims in terms of ill mental health. What am I doing to really address early intervention and prevention? We've come up with this concept of cultural tuning. You know your people, you know your organisations. Is what you're doing appropriate to your people, to your culture, and can you do more? So that is how we decode data. We obviously have the privilege of the data. Come and talk to us, because we're happy to share insights into how we can support organisations do better. But there is a real opportunity here, because health and well-being is booming. You're here because you're investing in mental health, and it's really important that we're taking targeted action, focused action for our people. A one-size-fits-all doesn't work anymore with mental health. It's around tuning your provision to match the needs of your people. So open the floor to any questions.
I can shout loud enough.
Yes.
So you touched upon DE&I. Are you collating data in the same way about DE&I? So, for example, race, disability.
Great question. Sometimes in some contracts we can, on others we're precluded to doing so. So it really depends on the organisation if we can collect it, then we do, because we know in terms of health inequalities how crucial DE&I information is. So yes, where we can, we do. Yeah, but it's a great question. Anything else?
The data that you shared about the reasons why people were getting referred at different age stages, I noticed there was a real difference between what was happening at the younger end of the workforce between men and women, and there was a lot of men being referred for work reasons, but that wasn't represented for women as well. Do you have any insight on what's going on? Because you talked a little bit about the immediate thing I thought of as well when you said it was, oh, you're entering the workforce, it's a whole new kettle of fish, you've been high achieving in academia, it's different here. But why is that different for women?
So again, another good question. So we know that women, from an evolutionary perspective, tend to ruminate more. So we know that that's one of the reasons why women have got higher prevalence rates of mental health. It would depend really on, I guess, the support and actually whether people feel comfortable to disclose the reasons why they're accessing therapy. So we do, Gen Z is a really, I mean, I could talk all day on this, but Gen Z is such a fascinating area. And they have got different needs, and we are really thinking, so that vulnerability, it's about assessing the vulnerability of people in your organisations from Gen Z and then scaffolding them appropriate. And it could be that actually males and females have different needs, which is what is shown in the data.
I think have we got an opportunity for just one last question just before we wrap up?
Which one, sorry?
I was thinking it's not my question, but the increase in children and young people's mental health.
I wish we had more than a minute. Very quickly, latent impact of COVID, for sure. Mixed evidence in terms of social media contribution. We also know that the cost of living caused differences in terms of both parents, in many cases, having to go to work, other blended families having to take on multiple jobs. So you ended up with a complete paradigm shift in terms of family units and the impact of and the correlation of the impact on mental health. We know that CAMHS referrals absolutely exploded as well. That's another session.
Yeah, and I think even on the last one, just to sum up, I suppose Shamira's already flagged that in terms of really looking at your own organisation and that whole concept of one size doesn't fit all, and you need to tailor it to your demographic.
Yeah,
would certainly be my take home.
Stratify and target and measure.
And that kind of wraps us up for the session. Thank you so much. It was really insightful.